Hi, everyone. Thank you so much for joining this afternoon. It's February 1st, which is kicking off February being Heart Month. We have a virtual series for Heart Month, and this is our first event. So today's topic will be Heart to Heart, how a cardiologist and a surgeon unite to save failing hearts. And our presenters will be Dr. Nathan Airhart and Dr. Sophia Airhart. They have a very unique story and a wealth of information and expertise between the two of them. So just before I turn it over, I'll just let everyone know we will do questions at the end, and you can type in your questions using the Q&A function. And at the end, we will get to questions. So with that, thank you so much to our presenters, Dr. Nathan Airhart and Dr. Sophia Airhart, and I will turn it over to you. Thank you.
All right, thanks, Simone, for the nice introduction. I'd like to thank everybody for tuning in on a Sunday. It is the start of Heart Month. We're excited to be able to deliver this presentation today. I'm Dr. Nathan Airhart. I'm a cardiac surgeon at Baystate Medical Center.
Hi, welcome everyone. I'm Sophia Airhart. I'm a heart failure and transplant cardiologist, the regional medical director of heart failure and the director of our pulmonary hypertension program. So I'll go ahead and kick us off, and then we'll bounce back and forth throughout the talk and tag team it. So this is our game plan for today. We'll start with a little introduction of ourselves and our paths to caring for patients with heart failure. Then we'll talk about really what heart failure is, how the disease progresses over time, the role of medications, and then what we do when medications aren't enough, namely what advanced therapies look like, and then how we, as a cardiologist and surgeon team, work together to improve both survival and quality of life. So this is my story. Nate and I both grew up in Oregon, and we met at Oregon Health and Science University in med school, actually walking to class the first day.
First day of class.
And then this is the beautiful Portland tram. Portland's a beautiful city. Then life took us on a bit of a zigzag. Really, career-wise, we prioritized the best training. So after med school, I headed to internal medicine residency at WashU in St. Louis. And then at that time, Nate was at Yale. Then after WashU in St. Louis, we both went to Seattle together. I was at the University of Washington for cardiology fellowship. And then I did my advanced heart failure and transplant fellowship at Allegheny in Pittsburgh, and also focused on pulmonary hypertension at that time. Even though we've had separate paths, we've always supported each other's journeys, and now we're here as a team.
That's right. So after medical school, as Sophia mentioned, I matched into general surgery residency at Yale, just down the road from Baystate. Luckily enough, though, I was able to land a 2-year research fellowship at WashU, where Sophia was, after my intern year. So I moved to St. Louis, and I did a research fellowship in vascular biology. After that, I transferred general surgery programs to University of Washington in Seattle, where Sophia was doing her cardiology fellowship. When she matched into advanced heart failure fellowship, I moved to Morgantown, West Virginia, just down the road from Pittsburgh, where I completed my general surgery residency. After that, I moved to Los Angeles, where I completed my cardiothoracic surgery fellowship at UCLA. And then finally, back to Oregon, where I pursued more training in cardiac transplant and mechanical circulatory support at Providence Heart Institute in Portland.
All right, and I'll hop back into, and we can share this part. So beyond just training and long hours, we've had a lot of fun on the way. And these pictures are snapshots of our lives, enjoying experiences in all these different places. So here we are at a Blazers game in Portland. Here we are doing a marathon in St. Louis. One of our favorite places in Seattle, hanging at Pike Place Market, not surprisingly, a rainy day. Then this is us on the river in Pittsburgh. Then my first faculty job was in Arizona. Nate and I did long distance when he was in LA. This is enjoying a nice desert hike. And then a sunny day in LA when we do weekend getaways there.
So yeah, we were really all over the place during training, but I don't think I'd do it any other way. I think that we gained a really broad perspective And I think it's made us better physicians.
Yeah, 100%. Each place had its own adventure, and we learned different treatment strategies and developed really a broad spectrum of tools in our toolbox to care for patients. So while we've had fun on the journey, what's really driven us both is this: that heart failure is affecting more people than ever. 1 in 4 people who are listening here will face it. And over the previous decade or so, heart failure mortality is getting worse, whereas before it was declining. So it's more and more important to address. Now that we know heart failure is on the rise, let's break down how it progresses, kind of the terminology we use. Heart failure doesn't develop overnight. We move from being healthy to being at risk. Being at risk means that you have risk factors for developing a weakening or thickening heart. That includes high blood pressure, diabetes, obesity. And then we move to stage B, which is when you have structural changes of heart disease, but you don't necessarily have symptoms. And then stage C is when you have symptoms of heart failure, like you're holding on to fluid, you have belly bloating, you have trouble breathing lying flat, worsening shortness of breath with activity. And this is really where a heart failure cardiologist comes in between stage C and D. Stage C, you have symptoms, but there's therapy options. And stage D, it's when you're getting worse despite medications and therapies. We can also describe patients' functional class, and class 1 is no symptoms. They can do everything they want to do without any limitations. Class 2 is slight limitations. Class 3 is you have significant limitations with your day-to-day life. And class 4 is essentially you're limited even at rest. And so over time, heart failure progresses. And the earlier we get at it, the better, and the more likely we can cause recovery and long-term quality of life. So we've talked about what the patient may feel and how we describe the progress, but what's really happening in the heart? When the heart gets injured, like from a heart attack or infection or longstanding high blood pressure where the muscle has to work a lot harder, some heart muscle cells are lost, and locally, the heart can get weaker, but also it kind of causes this whole body reaction where you can feel weakness and fatigue, and these work back and forth. Just to break it down in a little more detail, this is what we talked about: at risk to structural disease, to symptoms, to refractory symptoms. And the earlier we catch the disease, the more likely we can recover the heart. But over time, when you have injury, whether it be untreated high blood pressure or blockages in the blood vessels around the heart, your healthy heart cells are replaced by scar. And when your heart has scar, it's really hard to heal. So the earlier we got it before it gets scar, the more likely we can do. However, the first step in treating heart disease, and how I'm often called in kind of as a problem solver, is clearing the windshield, namely figuring out why is the heart struggling. To best treat the heart weakness and symptoms of heart failure, we need to know the cause of heart failure. And once we know the cause, we can really tailor the treatment to the patient. Although in a lot of different causes of heart failure, medications can make a huge difference. And medications have been shown to improve patient survival by as much as 6 years. So these remodeling meds is how I describe them, or heart strengthening medications, can make a big difference. And we titrate them to goal doses. And in addition to improving duration of life, they also improve quality of life. However, sometimes it's too late for medications. And that's another way where we work as a team to treat patients. And then we can consider more options for heart disease if we can't reverse the disease progression, and we think of heart replacement or heart mechanical support. So this is where someone like me comes along. Think of me as the quarterback, making a game plan, figuring out why the heart's struggling, tailoring the plan, and optimizing the therapy. I also track progress over time. Oftentimes we can delay the progression of heart disease, but I need to figure out when the patient's not doing as well and then figure out best next steps and coordinate with the whole team, including surgeons. And so I'll pass over the baton.
So as a cardiac surgeon, my job is really to restore structure and function to the heart. So this can be through addressing structural heart problems like blocked arteries, valve disease, or mechanical complications such as a ventricular septal defect or a ruptured papillary muscle. I provide options when medications aren't enough, as Sophia mentioned. I have to operate with careful timing and judgment. I think choosing when to operate is even more important than deciding what I'm going to do or how I'm going to do it sometimes. And it's important that I work as part of the heart team. We make very close collaborative decisions with our cardiology colleagues. And really the goal of operating is to aim for a durable, long-term benefit where the patient can recover and have a good quality of life after surgery. So a little bit about Baystate. This is really a place where we can provide comprehensive heart failure care under one roof. It goes all the way from early diagnosis to the most advanced therapies. We work with a multidisciplinary heart team model, which includes advanced heart failure cardiology, the cardiac surgeons, imaging, nursing, and other support services. And like I said, we all work very closely together. We have access to advanced therapies, including very specialized medications, devices, and surgical options when needed. And we offer personalized treatment plans. It's very important to tailor care to each patient's individual condition and to their goals and their stage of disease. And finally, we have a commitment to continuity within our community, and we have coordinated care for patients all across Western Massachusetts and even beyond. So this is kind of a map of our care network, which, as you can see, extends all across Western Massachusetts into Northern Connecticut and even Southern Vermont. So we have a very wide catchment area for our patients. So as we mentioned, it's very important to make shared decision-making from the start between all of the members of our heart team. We need to have early, honest conversations about options for the patients. We need the right treatment, we need the right timing, we need the right team, and we develop one plan centered on the patient. So this is our heart team. We have an amazing group of 11 cardiac surgeons and intensivists, along with almost 20 advanced practice providers, including PAs and nurse practitioners. On the advanced heart failure cardiology team, we have 4 dedicated advanced heart failure cardiology transplant cardiologists, as well as several advanced practice providers. And beyond that, we have dedicated cardiac surgery anesthesia, interventional cardiology, cardiology imaging, a structural heart team, and we all work together to take care of our patients.
With the patient at the center.
That's right. So I think in order to best illustrate how we take care of our patients and the spectrum of care we can offer, we'll go through a patient's story. We'll call him Mr. B. This is a patient who presented with long-standing heart muscle weakness. He had a non-ischemic cardiomyopathy, and he was really developing worsening shortness of breath and fatigue, which limited his activity significantly. And as his heart failure progressed, he had to be admitted to the hospital. When he was admitted, testing showed that his heart was getting weaker. And because of this, his other organs were starting to struggle too, including his kidneys and his liver. And it got so bad that he was starting to require IV medications just to keep his blood pressure stable.
And so just to provide a little more context, usually what happens is basically when a patient comes into the hospital, they're seen by the ER or internal medicine, and then they loop a cardiologist in. And then if the patient isn't doing too well, they loop a heart failure cardiologist in. And then when we feel appropriate, we loop the surgical team in to make a plan together. So again, a full team.
So class 4 heart failure. This is when the heart team stepped in, as Sophia mentioned, advanced heart failure cardiology, the cardiac surgeons. We even had members from our social work team, our palliative care team, RN coordinators, pharmacy, physical therapy, nutrition. And we all got together and had a multidisciplinary heart team discussion in order to make a decision on where we were going to go next. Now, as I mentioned, this patient was very sick, and our decision that we made for him was to try to get him to where we could implant a permanent heart pump or an LVAD so that he could get out of the hospital and start to live a normal life again. But when he came in, he was sick. So we needed something that could temporarily bridge him to stability where he could undergo this big operation. So the decision was made to place a temporary heart pump. This is a microaxial flow pump or an Impella 5.5. And the goal of this is to really support his heart and circulation. This is what the device looks like. The patient is taken to the operating room and we do a small incision right under the right collarbone. We expose the axillary artery and sew a graft to it. And then through the graft, we deliver the heart pump or microaxial flow pump through the axillary artery, down through the ascending aorta, across the aortic valve, and into the left side of the heart. Once the pump is in the left side of the heart, we activate it, and it can actually provide about 5.5 liters of flow, which completely unloads the left ventricle of the heart and supports the cardiac output and supports the rest of the organs in the body. What's great about this device is after it's inserted, it can be secured to the patient, and the patient can get up, move around, start to regain strength, and prepare for the next step in the operation, which is the durable LVAD. So temporary mechanical support allowed our patient, as I mentioned, to get out of bed and walk. He was able to regain a lot of his strength, and his kidneys and his liver actually recovered fully. Over the course of the next several weeks, we carefully reassessed him. And when he was ready, and the team felt that he was ready, we made the decision to proceed with a durable heart pump or an LVAD. And once again, the goal was to get him a long-term support device in his heart where he could have quality of life and live at home. So this is what the durable LVAD looks like. This is a HeartMate 3. This is a device that's actually implanted into the left ventricle of the heart. And it has a centripetal pump that directs flow from the left ventricle out through an outflow graft into the ascending aorta. And what this does is it augments the cardiac output significantly and takes over for the left-sided heart failure. Patients can then be discharged to home. They have a drive line that comes off of the device that exits their abdomen that they wear in a little backpack here that connects to a battery. There are several indications for LVAD implant. One is a bridge to transplant for patients awaiting a heart transplant. One is a bridge to candidacy for patients who are being optimized for transplant. These patients may have contraindications to transplant, such as pulmonary hypertension, kidney disease, or obesity that may improve over time after they do receive support from the temporary heart pump. Destination therapy, as Mr. B underwent for non-transplant candidates. And a new emerging role for LVADs is bridge to recovery. And this is for patients with reversible causes of heart failure, such as non-ischemic cardiomyopathy, myocarditis, or other inflammatory cardiomyopathies. Overall survival with the HeartMate 3 is actually very good. After 2 years, patients with severe heart failure who receive LVADs, 80% of them are still alive. And mean survival in these patients exceeds 5 years. Contrast this to survival with medical therapy alone, where only 20 to 50% of patients with advanced failure are alive after 1 year. Younger patients do even better with LVADs. In patients less than 50 years old, 5-year survival ranges from 70 all the way up to 80%. Finally, we see similar survival between HeartMate 3 patients and patients who actually get heart transplants at younger ages. 2-year survival is 90% with HeartMate 3, and this matches our transplant population. So a strategy of HeartMate First as a bridge to transplant can actually extend the survival of our younger patients, which offers a net prolongation of their life. There are some contraindications to LVAD. One is limited life expectancy. They may be advanced age. They may have another disease which has poor anticipated survival. They may have other comorbidities such as kidney disease, advanced liver disease, really bad lung disease. They may be severely malnourished or frail and not able to survive such a big operation. They may have hemodynamic or anatomic contraindications, such as severe right-sided heart failure, which is important to consider. And they may have psychosocial contraindications, including the inability to adhere to a medical regimen. You have to have close follow-up once you do have one of these devices, and it's important that you're able to follow that. So we got Mr. B through this complicated surgery. His LVAD was implanted successfully. However, after this LVAD was placed, the right side of his heart still needed temporary assistance while it recovered. So because of this, we placed a temporary RVAD, which was to support the right ventricle of his heart. And this is a schematic of how that works. A graft is sewn into the right atrium or IVC usually, and that side of the heart is drained into a pump. The blood is returned back to the pulmonary artery, which significantly unloads the right side of the heart, allows it to rest, and allows it to recover in the postoperative period. So, in fact, his right heart did recover. We were able to take out the RVAD support after a few days. And once again, with our teamwork, cardiac surgery, heart failure, cardiology, intensivists, etc., the patient rehabbed over the course of the next 10, 12 days, and he was discharged to home, able to go back to living a fairly normal life with his family and feel much better. So why did this work? We had early recognition of progression. We had open communication between cardiology and surgery, and we utilized temporary support very thoughtfully. We utilized the Impella 5.5 to get him rehabbed before he underwent the big LVAD operation. And then afterwards, we were able to help his right heart recover with the temporary right ventricular assist device. And then finally, we were able to offer patient-centered decision-making, making sure we were doing the best thing for him and his family.
Yeah, thank you. Excellent case. One of the most rewarding things I do is see patients as they get better. And I really enjoy seeing patients like him in clinic, out of the hospital with more quality of life. So not all patients, VAD is the best fit. And when I say VAD, I mean ventricular assist device or mechanical heart pump. Some patients, the risk doesn't outweigh the benefit. And some patients would rather focus on quality of life at home or may be candidates to be considered for heart transplant. So every patient's path is unique and thoughtful and patient-centered. With regard to heart transplant, we're not a heart transplant center, but we collaborate very closely with several of the Boston programs, most closely with Beth Israel Deaconess. Myself and several of my colleagues are actually on staff at Beth Israel, and we go there throughout the year. So we're an integral part of their transplant team. And this allows us to take care of patients before we refer them to transplant. We can start the evaluation. Then they go there, meet them in person, get further diagnostic testing. And then if they are a good fit for transplant, then we also have the capability of taking care of them afterwards for continuity and local care. So that's really amazing. One of the things I want to highlight as a take-home point from this talk is the earlier we see patients, the more we can do. There's a simple I need help checklist, which is helpful often for general cardiologists, sometimes for primary care. in terms of when patients should be referred to the advanced heart failure team. Clearly, if they're needing inotropes, which is an IV medicine supporting the heart, if they're having symptoms with rest, which is what we briefly talked about as NYHA functional class 4 symptoms, if they're having end organ dysfunction related to the heart, meaning their liver's not happy, their kidneys aren't happy, their heart squeeze is less than 20%, normal is about 55%, so that's quite low. If they're getting shocked from a defibrillator to kind of reset their heart, that's a warning sign. Being in the hospital multiple times, if you're on medicine to cause you to pee and you need higher and higher doses, or that can be a warning sign. Low blood pressure or inability to tolerate heart strengthening meds, those are also warning signs. So how to reach us? This is the link, and you're welcome to reach out. We're also available online and would be happy to see people in clinic when appropriate, of course. And so I hope you take home from this lecture that heart failure is treatable, that timing really, really matters. Team-based care is essential and saves lives, and quality of life matters. So this is what the goals look like, not just survival, but quality as well. So thank you so much for being here and trusting us with your hearts. And we're happy to take any questions, although my husband may have to step out because someone might need him.
Yeah, thank you.
Thank you to both of you. We do have some questions, so I'll start going through those now. First question, is AFib a symptom of CHF?
Yeah, it goes back and forth basically. So atrial fibrillation often occurs when the top chamber of the heart or the filling chamber of the heart gets stretched. And if you have stretch on your heart, that causes AFib, but AFib also causes symptoms of heart failure. So it's the chicken or egg sort of thing, and it depends on the patient and the timing. But it's really important to treat AFib to control heart failure symptoms. But sometimes people have AFib without heart failure, and the earlier we treat AFib, then the less likely they are to develop heart failure.
Thank you. I have a question of someone saying they underwent cardiac ablation. Does the procedure predispose them to future CHF?
No, not really. I mean, the fact that like if it successfully kept you out of AFib, then that's wonderful and that decreases your risk. Being in AFib chronically can cause heart failure if the heart rate isn't well controlled or if you're having symptoms from it. But ablations are a common treatment strategy, especially to minimize the need for long-term medications for rhythm problems.
Thank you. And BTR LVAD patients, are they able to live without the LVAD at some point?
Yeah, that's the whole goal. It's important that we, once again, identify these patients who might be potentially recoverable, and we go into their journey with an LVAD with the goal of recovering them. So frequent reassessment throughout their period with the VAD, getting them on the best medical therapy, goal-directed medical therapy, and sometimes, and I think depending on the patient, a lot of them, if you go into this with the strategy of recovery, they can recover and the VAD can be explanted and they can go on to live without the LVAD.
Yeah, to add to that 100%, active management for recovery is really important. And so it's also important that when patients get a durable left ventricular assist device or a mechanical heart pump that you can go home with, that we follow them closely and they stay on heart strengthening medications. And it depends on the cause of the heart failure. So, sometimes people get like peripartum cardiomyopathy or like a toxin-induced cardiomyopathy. I recently cared for someone with an alcohol-related cardiomyopathy. They were able to quit alcohol before they got their pump. And now that they've been able to sustain off of alcohol, their heart is showing signs of recovery. And they may be a candidate for explant, although that requires another team-based careful management approach. To optimize the pump outflow, it's important to lower blood pressure because it's hard for the pump to work against high blood pressures. And we also optimize the right heart function. But long story short, yes, the goal is recovery, but it really depends on the substrate.
Yeah, and like I said, it's important to identify these patients early, who might be a candidate for recovery, and then aim for that throughout their LVAD course.
Thank you. So about the patient story that you shared, of course, we're keeping that anonymous, but someone's just wondering if you could share the age of that patient for reference.
Yeah, so Mr. B is a fictional patient, but he does represent a lot of the patients that we take care of. Patients' ages really do range from their early 40s all the way up to the mid upper 70s.
Yeah.
Thank you. Next question. Can you address advanced diastolic dysfunction with a normal ejection fraction treatment?
Yeah, that's a great and very important question. So people with advanced diastolic dysfunction or heart failure with preserved ejection fraction basically have a very stiff heart muscle. And that stiff heart muscle causes them to hold on to fluid. And often they are as limited, if not more limited, than people with weak hearts. And they can hold on to fluid and feel short of breath with day-to-day life. And the treatment strategies for those patients are different in many cases than those people with weak hearts. One of the most important things in people with stiff hearts is figuring out why they have a stiff heart. If it's something like amyloidosis, which is protein depositing in the heart, then there's a very specific treatment for that. If it's like hypertrophic cardiomyopathy, there's a very specific treatment for that. And that's when a heart failure cardiologist can come in and help. One of the most common causes of diastolic dysfunction is untreated high blood pressure for a period of time. But really, to answer your question in more detail, LVADs or left ventricular assist devices aren't good fits for people who have stiff hearts instead of weak hearts. But those patients, if they are limited and the right candidates, can also be considered for transplant depending on the pathology. But our treatment in impaired relaxation of the heart is also rapidly advancing and becoming more and more targeted, almost like cancer treatment, where we're looking to, be very specific to the disease etiology. So it's an exciting field.
When ventricular arrhythmias or ICD shocks increase, does that usually push you to refer for advanced heart failure therapies sooner?
Yep, good catch. And that's on the red flag, I need help algorithm. So another question is, why are these shocks increasing, right? If we have a very clear treatable cause, then that's one thing. But if the shocks are progressing because the heart is getting weak, and there's more electrical disturbance, despite people being maxed out on good medications that decrease those risks of the rhythm problems, then people should be considered for advanced therapies or have discussion with the team to see best next steps.
Thank you. That looks like it was our last question, but I'll just give people a minute. Sometimes people are still typing their questions, so I'll just make a quick plug for our upcoming Heart Month events. We do have another one next Sunday, which is February 8th. That topic is Beyond the Blockage, Transforming Peripheral Artery Disease Treatment. So that will be next Sunday, same time at noon, and same format. And just checking to see if any questions have come in. Looks like we don't have any further questions, so I'll just thank you both so much for joining us today and sharing all this great information and taking all of our questions. I really appreciate you spending some of your Sunday with us. So thank you very much, and thank you to everyone for joining.
Thank you, everyone.